welcome back again. So let me continue my talk with the topic on the diseases of retina and vitreous. So this is the anatomy of the eye again, and here the yellow one is the retina. So retina is retina needs to be protected because retina serves as a neurosensory organ, sensory organ of the lights of the picture, right? So without retina we cannot see, and there is an area here called macula. Macula is in the central. It is where most of the picture of the light is received, and the central area of macula is fovea, and the center of the fovea is called foveola. Fovea is the place where the picture is the clearest, and the foveola is the place where there are only cones without dots, so the picture is very clear. So macula is important area, is an important area, and macular degeneration is the most common cause of untreatable or incorrectable blindness in adults nowadays. And here it is the optic disc, right? So this is bright spots. There are no cones or rods here. There is no neurosensory retina here. So here does not receive any picture, does not receive any picture. And then the nerve fiber will come here together and form the optic nerve, which is surrounded by meninges. So when there is increased intracranial pressure, the optic nerve will be compressed, and we may see a characteristic eye change of the chronic hydrocephalus or chronic increase in intracranial pressure, so which is papilledema, swelling of optic disc. And this is the structure of the retina. The posterior segment contains vitreous, right? วุ้นลูกตา and the retina has 10 layers: inner limiting membrane, nerve fiber layer, ganglion cell layer, inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer, and external limiting membrane, and rods and cones. These are together called neurosensory retina, retina, and rods and cones are taken care by retinal pigment epithelium. If there is separation between retinal pigment epithelium and the rest of the retina, that is called retinal detachment. If there is a separation between the inner limiting membrane and the vitreous, that is vitreous detachment. When there is hemorrhage, if the hemorrhagic area is within the nerve fiber layer, because the nerve fiber layer is aligned horizontally, so the hemorrhage will be seen as flame-shaped hemorrhage. Whereas if the hemorrhage is within the inner layers, the nerve fibers are aligned vertically, so we will see the hemorrhagic area as dot hemorrhage. And when there is a leakage of fluid from blood vessels, we may observe exudate in the outer plexiform layer. exudate is seen in the outer plexiform layer. Exudate is seen in the outer plexiform layer. So vitreous humor is vascular in adults, and aging changes are also common, and some of you may also have it. Flutter, just like it is the result of liquefaction and collapse of the vitreous. It is just like the patients will explain as they see yak yai, they see something floating in the eye. The floaters will just like will go along when we move the eye. So that is floaters. And the posterior vitreous detachment is also a serious condition. It is the separation between the posterior hyaloid, posterior surface of the vitreous humor and the retina, the inner limiting membrane. So retinal detachment. So retinal detachment is the separation between neurosensory retina and the retinal pigment epithelium. So it is as so we can divide the condition into two groups: rectomatous, that is breaking of the retina, and non-rectomatous, no breaking of the retina. Rectomatous is associated with full thickness retinal defect. So when there is vitreous collapse, the posterior hyaloid exerts traction on the points of abnormally strong adhesion to the inner limiting membrane, and there is seeping of the liquefied humor into the retina. So which results in progression of the retinal detachment. And for non-rectomatous retinal detachment, it can be seen in malignant hypertension. Malignant hypertension results in excessive exudation from the blood vessel, and also another cause of non-rectomatous is choroidal tumors, which results in damage of retinal pigment epithelium and fluid leakage from the choroidal circulation. So here, non-rectomatous retinal detachment. So retinal detachment is a separation between neurosensory retina and retinal pigment epithelium. Right? So that is accumulation of protein-rich fluid in the subretinal space. The common causes are malignant hypertension and choroidal tumor. For rectomatous retinal detachment, there are various causes, including diabetes, including any conditions that results in retraction of the vitreous, and then the traction of the retina and breaking of the retina, rectomatous retinal detachment. Unlike retinal detachment, the vitreous detachment is a separation between posterior hyaloid and internal limiting membrane. So retinal vascular diseases may be associated with hypertension, diabetes, retinopathy of prematurity, sickle retinopathy, retinal vasculitis, radiation retinopathy, and also retinal artery and venous occlusion. So hypertension, so as seen in any organs in the body, so we may see uh, thickening of the blood vessel wall, and we may observe the exudate, right? So when we look in the eye using ophthalmoscope. Using an ophthalmoscope, we may see there is a thickening of the arteries within the retina, and the thickened artery wall may result in here compression of the venous blood vessel, and the thickening of the blood vessel wall may result in decreased saturation of the blood within the blood vessel. So we may observe it as a copper wire. If the obstruction is more severe, we may observe the blood vessel as silver wire, silver wire, W-I-R-E, silver wire. And so if the hypertension is severe, we may observe hemorrhage here. So hemorrhage here will be seen as flame-shaped hemorrhage. And we may observe the degeneration of this area, the nerve fiber layer. We may observe cytoid body histologically, but no one will do the biopsy. So we will see this lesion as cotton wool spot. And next condition is diabetes mellitus. So diabetic retinopathy is a common cause of blindness amongst diabetic patients, and reliable histologic marker for diabetes is the thickening of the basement membrane of pars plicata of the ciliary body. It's like here. There is thickening of the basement membrane of pars plicata. However, we don't do this to make the diagnosis of diabetes. So just know it briefly. Don't have to go into detail. For the retinopathy itself, the diabetic retinopathy is divided into two broad stages: pre-proliferative or background diabetic retinopathy and proliferative diabetic retinopathy. The abbreviation for diabetic retinopathy is DR. So background or pre-proliferative diabetic retinopathy, all the pathologic changes are confined beneath the internal limiting membrane. So there is thickening of the blood basement membrane of blood vessels. The polycytes are diminished. There may be microaneurysm, macular edema, and intraretinal microangiopathy. So decreased blood flow to supply the retina results in ischemia. Ischemia activates secretion of VEGF, vascular endothelial growth factor. VEGF stimulates angiogenesis, and which results in intraretinal microangiopathy. So the cutting line to separate between background and proliferative diabetic retinopathy is the internal limiting membrane. If the lesions are seen beneath the limiting membrane, that is pre-proliferative or background DR. But if the microangiopathy, if the vascular proliferation extends through the internal limiting membrane, that is proliferative diabetic retinopathy. So background diabetic retinopathy does not need to be treated. Only well control of the diabetes is enough. But if the stage progresses into proliferative diabetic retinopathy, some treatments need to be performed. You may have heard that some diabetic patients need to have laser of the eye. So the laser will destroy new blood vessels, which are very fragile, and sometimes the doctor may just destroy the retinal tissue in the periphery to decrease the oxygen demand, and which results in decreased production of VEGF, and, and stop the progression of diabetic retinopathy. Neovascularization within the retina is called intraretinal neovascularization, right? But if the vascularization extends through the internal limiting membrane, that is proliferative diabetic retinopathy, and the new neovascular membrane is very problematic. It can cause so many complications. The vascular membrane may contract, so may be organized. So one complication is posterior vitreous detachment, and then posterior vitreous detachment may be complicated by traction retinal detachment. At the beginning, retina may not be broken, but in the end, the retinal detachment may become retomatous retinal detachment. And if the neovascular membrane develops within the iris, it may cause anterior synechiae, and the organization or contraction of the membrane can result in neovascular glaucoma, which is a type of angle closure glaucoma. So the treatment is ablating non-perfused retina by laser photoablation or cryopexy. So on the left side here, it is the neovascularization beneath the internal limiting membrane. So this is only in the pre-proliferative or background diabetic retinopathy. But if uh, this neovascular membrane extends through the internal limiting membrane, this is proliferative stage of the diabetic retinopathy. So here we see a lot of neovascularization. So this needs to be treated. This needs to be treated. So the neovascularization is very problematic. So it may result in hemorrhage into the vitreous from the fragile blood vessels, and the contraction of the membrane may result in vitreous detachment, may result in retinal detachment, which are very dangerous. Retinopathy of prematurity. Another name is retrolental fibroplasia. Retrolental fibroplasia. It is a form of oxygen toxicity. Oxygen toxicity. So the newborn, just like particularly the premature newborn, those who premature or preemie, they are usually treated with oxygen. They are usually treated with oxygen because the lung problems is very common amongst preemies. And so when the oxygen is given to the children, the blood vessels will be constricted, so which results in ischemia, neovascular membrane dragging, and displacement of macular laterally, and retinal detachment. So this is an example of oxygen toxicity. Too much oxygen results in vasoconstriction and ischemia. So we need to be careful. We need to be careful when oxygen is given to the preemies. And retinal artery occlusion. So if the occlusion is within the branch, there may be segmental infarction. If the occlusion is within the central artery, the infarction may be diffuse. And the infarction, the occlusion results in haziness of the retina, So the retina will be hazy, but this area at the fovea and foveola, the retina is very thin. So that is why we don't see so much haziness here. So we see it we see the choroid color, the color of the choroid. So choroid is highlighted by surrounding opaque retina. This is called cherry red spot. This is the cherry red spot, which is a characteristic feature of the retinal artery occlusion. If the occlusion affects retinal veins, so just like there may be ischemia resulting in neovascularization, or the occlusion may not cause ischemia but cause instead hemorrhage and exudates and macular edema. Age-related macular degeneration is the most common cause of irreversible visual morbidity. The factor is the advancing age. The etiology is still unclear. It can be associated with smoking, nutritional conditions, and vascular pathology, including atherosclerosis and hypertension. So this condition has to do with the disturbance of the functional unit of retinal pigment epithelium, Brooks membrane, which is the basement membrane of retinal pigment epithelium, and choriocapillaris, which is the innermost layer of choroidal vasculature. So this condition is divided into two big stages, dry or atrophic ARMD, age-related macular degeneration, and wet or exudative stage of age-related macular degeneration. So then we may, in the dry stage or atrophic stage, there may be drusen. This is quite characteristic, which is a deposit in the Brooks membrane, and we may observe the geographic atrophy of the retinal pigment epithelium. But in the exudative stage, the hallmark is choroidal neovascular membrane, which originates from choriocapillaris and penetrates through the Brooks membrane. So when there is leakage of the membrane of the blood vessels, so there may be organization and macular scar, and sometimes there is hemorrhage, which results in localized suffusion of blood or diffuse hemorrhage. So here is the figure demonstrating the retinal pigment epithelium here, and we see Brooks membrane, which is the basement membrane of the retinal pigment epithelium, and underneath here is the choriocapillaris, and in the dry stage we may only observe the deposits in the Brooks membrane, but in the wet stage or exudative stage we may observe the vascular membrane originating from the choriocapillaris and penetrating through the Brooks membrane into this space. So this is the exudative stage of macular degeneration. And retinitis may be caused by candida, which is a fungus which comes here through the blood vessels, or CMV retinitis is a common opportunistic infection of in the HIV patients. And retinoblastoma is the most common primary intraocular malignancy in children. 40% are associated with inherited mutation of one retinoblastoma allele. And retinoblastoma can be unilateral, affecting only one eye. It can affect both eyes, which is bilateral, and sometimes the patients may also have pinealoblastoma, the malignant tumor of the pineal gland. This is rare, but it can be seen. So we will call those with retinoblastomas in both eyes and also pinealoblastoma trilateral retinoblastoma, trilateral, 3 sides. So here we see a shine, and we don't see the light reflection here. มีตามีแววไหมไม่มีแววตรงนี้ so if we see something like this, we need to be careful, because this may be a sign of retinoblastoma of this eye, retinoblastoma. And here is the mass within the eye. So as I mentioned earlier, if you see a mass within the eye of a child or an infant or a newborn, that is retinoblastoma. If you see a mass within the eye of an adult, that is melanoma. So different origins. The malignant melanoma originates from the choroid, but retinoblastoma originates from the retina. And as commonly seen in the blastomas, the retinoblastoma is composed of small blue round cells. The cells grow very quickly, so we expect to see necrosis, mitosis. In the necrotic area, we may observe cardiolexis, pycnosis, and we can observe both hemorrhoid pseudorosette or Flexner Wintersteiner true rosettes, which are these tubular structures. These are Flexner Wintersteiner rosettes. They have true lumens in the middle. So because the tumor cells are trying to form photoreceptor, so this is a characteristic feature of retinoblastoma, Flexner Wintersteiner. But overall, just like the tumor is composed of small blue round cells with scant cytoplasm. So retinoblastoma may spread to the brain and the bone marrow, and seldom to the lungs. And the benign variant is also can also be seen. So sometimes retinoblastoma is seen in one eye, but the other eye has neurocytoma. So this is a characteristic feature of the heritable retinoblastoma. The prognosis depends on the presence of extraocular extension, optic nerve invasion, or choroidal invasion. Then optic nerve conditions. So the optic nerve is surrounded by meninges with CSF circulating around the nerve. So when there is increased intraocular, not intraocular, increased intracranial pressure, when there is increased pressure of the CSF, the optic nerve will be compressed. So when the optic nerve is compressed, we may able to see an important sign, which is papilledema, the swelling of optic disc, the swelling of optic disc. And for optic nerve itself, the most common primary neoplasm is glioma and meningioma, just like the brain. And anterior ischemic optic neuropathy may be transient uh, ischemia or infarct, segmental versus total, and the result is permanent visual loss. The causes including embolic and thrombotic, and also the arthritic cause includes the temporal arthritis. Temporal arthritis. So the figure on the left side represents the anterior ischemic optic neuropathy. Optic neuropathy. So there is ischemia of the optic nerve, and we can observe swelling of the optic disc, which is the head of optic nerve. And this swelling is associated with paleness. So the lesion seems to be pale because of the decreased blood perfusion within this area. On the contrary, on the right side, we see swelling of the optic disc associated with hyperemia, that is increased blood uh, within this area. There is engorgement of the blood vessels here. So this is papilledema, papilledema, the edema of the papilla, the edema of optic disc, which is the head of optic nerve. This condition is very important. If you observe anyone with papilledema, you need to be careful because this can be a sign of something in the head. It is a sign of increased intracranial pressure. Chronic increased intracranial pressure just like may be detected using an ophthalmoscope. Papilledema. The inflammation of the optic nerve can also be seen. It is loss of vision secondary to demyelination, and the most common cause is the multiple sclerosis. You will learn about this condition in a lecture on the nervous system that's coming soon within this month. And any condition that destroys the eye will become end-stage eye, which is called phthisis bulbi. Phthisis bulbi. So the eye structure is totally distorted. So this is, of course, just like causes blindness, permanent blindness to the patient. So that is all I would like to mention to you. So I know that there are many new terms that you have never heard before, but just learn about them. They are not so difficult. So thank you very much for your attention. So thank you very much, because if you see this slide, it means that you have followed through my lecture to the end. So thank you, and hope to see you again sometime after the COVID-19 virus infection outbreak. Thank you. See you. Bye bye.